Afternoon, everyone, and welcome to our afternoon session entitled The Ripple Effect, Promoting Female Leadership in Academic Global Health. It's really great to see all of you. Before those of you in the back get too comfortable, given the size of the room and the sort of intimate nature that we're going to have with our panel discussion, we really want many of you to come up further up. So if you have to leave early, that's okay. We won't take offense. But please do, if you don't mind, those of you in the way back, it'll just make it for a more engaging interaction. So I think we're going to have a lot of fun with our panel this afternoon. We've lined up some diverse perspectives, and you'll hear from our speakers today about their perspectives of global health, both from an academic perspective, personal perspective, political perspective, and any of the like. I don't want to steal away their thunder. The sort of goal of this panel is to really have a conversation about being a woman faculty, a woman researcher engaged in global health. We have women who've just started their careers and are about to move forward. And I know many of you in the audience may be coming at this from different perspectives as well. And those of you who've been in the field for many years may have a lot of wisdom and reflection to share with us this afternoon. So to start out our panel, I thought it'd be great first to see who's in the audience. I'm interested to see how many of you are US-based academic global health researchers or engaged in global. Raise your hand. Okay, great. And how many of you are engaged in global health from the perspective of being in low and middle income country based? Raise your hand. Okay. So it looks like we have a majority of many individuals here who are actually US-based but engaged in global health. So that's actually very helpful to know who our audience is. Terrific. So without further ado, I'm Amita Gupta, and I'm an associate professor at Johns Hopkins. I'm based in the Infectious Diseases Division in a Center for Clinical Global Health Education, and I have a joint appointment in international health at the Bloomberg School of Public Health. And much of my work for the last decade and a half has been engaged with doing infectious diseases research, largely in India, but I also do multi-country work. And so you'll hear from a little bit about my perspective later on. Sitting next to me is Ingrid Katz, and I'm going to have Ingrid introduce herself.
Thank you so much. My name is Ingrid Katz. I'm a physician at Brigham and Women's Hospital. I'm trained also in infectious diseases. And my primary focus has been on HIV and HPV in South Africa. I've worked there for the past 8 years, trying to develop interventions to help people engage in care.
Hi, I'm Jyoti Mathad. I'm an assistant professor at Weill Cornell, also out of a Center for Global Health. Amita has been my mentor, so my work has largely been in India as well, but I also do work on tuberculosis and maternal health in Haiti, as well as India. And in my off time, I've been working on this issue that we're talking about today and trying to improve leadership in global health research. So I'm so excited to see you all here today.
My name is Yuka Manabi. I'm a professor at Johns Hopkins University of Medicine, Molecular Micro and Immunology, as well as International Health over in the School of Public Health. And my focus has primarily been on tuberculosis. I started out as a bench researcher and then became interested in immune reconstitution phenomenon and realized that what I saw in my rabbits was happening in Africa. So when given the opportunity to move to Uganda in 2007, the epicenter of the HIV epidemic, as an infectious disease physician, the epidemic of my lifetime, I decided to move to Uganda and then was supposed to stay for just a year and then stayed for 5 years, brought my whole family and really enjoyed it immensely. I've continued to work there. I do a lot of epidemiology now in addition to some translational work and have become more and more interested in diagnostic certainty and frugal innovation in diagnostics.
I'm Michelle Berry. I'm the dinosaur on the panel. I'm a Senior Associate Dean of Global Health. I've been involved in clinical tropical diseases for greater than 30 years. I've spent most of my career at Yale, running overseas programs in really for residency programs as well as for infectious disease fellows, and I'm now running a Center for Innovation in Global Health at Stanford.
Terrific. So I think you'll all agree this is a star-studded panel of of individuals. Now, what's also interesting to me is if I look around in this room, I see that we have a predominance of women in the audience. And that gets me to, but we have, I think I see some strong supporters of women and global
There are
health.
some men who get it here.
And I appreciate that. We always, whenever you put in female in the title, we end up attracting, I think, just by and large, more women in the audience. But in any case, we welcome all of you. And I think one of the premises is to understand the fact that, interestingly, in terms of looking at statistics for global health, we know that when we look at programs of global health, 80% of the individuals who are undergraduates going into sort of global health fields are actually female. When we look at those who are residents and medical students rotating in global health experiences, we have about 40%, about 60% of them are female, and then faculty engaged in global health is about 40%. And then when we look at leaders of global health at academic institutions, that's a much lower number, and that's only about 24% of directors are global leaders of their centers for global health. And so we know there's a large number of individuals who are female who are very interested and are seeking experiences throughout their training, but as we rise up to look at the leadership of global health, that sort of, we have a thinning or a pyramid that has appeared. So that's not actually that different from what we see in many of the other professions, though in healthcare we know there are many, many women who are engaged in healthcare, both domestic and international. So with that in mind, I think it's really would be interesting to hear from the panelists about why we think that may be important. We know that there is that phenomena, but do we think it matters? And if so, I'm going to first ask some of our comments from our panelists about whether we think this is an important issue.
So we've done a little bit of research into whether it matters. You know, sometimes we strive for gender parity just for the sake of gender parity, which is an issue on its own. But when you look at some of the development literature out there about what happens when females are leaders of villages in places like India or Afghanistan, you can see tangible differences. So there were some studies that were done that looked at like in a village in India, they looked at elections that were very close, where either a woman or a man won by a small margin. So it was basically chance whether or not the woman or the man won. And in those villages where the women were leaders, there was a drop in neonatal mortality by 1.5%, which is huge. A lot of those villages had more of their adolescent girls that stayed in the education system and were able to get more education. They had less household chores to do. So it may seem somewhat intuitive, but it does seem that female leaders do make slightly different decisions than men do in some scenarios. Of course, I'm sure there are studies that show there are no difference, but at least there are some that show that there might be a difference. And so I think we strive for increased female leadership, especially in this era of global health, where a lot of the major issues where we're not meeting the mark with our UN MDGs, for example, a lot of them had to do with maternal health or women's health issues or access to reproductive care. Those were the ones we failed on. And so perhaps if we had increase in female leadership and more women in the rooms where these decisions are being made, where dollars are being spent, it could make a difference for women's health globally.
No, I'd like to give a little bit of a more even global perspective, and that women play a huge role in community healthcare workers. It's well known if you empower women, you make a difference in health. And then I want to just bring it home a little bit to say that 75% of my students going into global health are women right now. There's a definite feminization of the career specialty. Maybe some of my panelists or the audience want to reflect upon that, whether they're seeing it. At the CUGH board, we had a whole discussion about it. So on the board, which is about 15 universities represented, there was pretty unanimous consent that this was actually happening at their programs.
Yeah, I would agree, and I just think that, so we're doing a better job filling the pipeline, but still if you look at leadership in global health, there is a male predominance still in the leadership that most of us see. Michelle excluded since she's on the... So I think that, as in all things, it's been noted that a diversity of opinion, ethnic diversity, gender diversity, certainly leads to sometimes more conflict in the beginning, but often more parity, equanimity, and in the end, a better decision when you see that diversity in anything that you do. And I think that decision-making it may take longer, but I do think that in general you get a better outcome. And so I think that's what this is about. This is not so much about the pipeline, because I would agree that at Hopkins the same is true for the public health undergraduate major, which is one of the most popular at Johns Hopkins. There are a lot of women that are going into it. Similarly, medical school classes, if anything, are becoming a little biased towards more women than men. So in terms of filling the pipeline, what you feel may be very different than when Michelle and I went to school, but I do think that when it comes to leadership, you may not find as many women role models as you might find amongst the men.
I think Michelle is going to touch on this later, so I don't want to steal her thunder, but I do think that some of us have had both women and men as mentors, and there are certainly outstanding men who, as Michelle likes to say, get it, and want to see women really rise up. And I think because they have previously, historically, been in more positions of power, often can provide ways to enter into this work, particularly through either mentorship or sponsorship. So it's not to say that it's an exclusive club. I think there's a lot of ways to kind of bring people together, and I'm sure Michelle will touch on this later.
So I think you've heard sort of some perspectives of that it appears to matter, and there's sort of some factual evidence that women in leadership positions can help influence both explicitly and implicitly both health decisions, policy, mentorship. And I'd be interested to hear, does anyone here in the audience have a different perspective and feel brave enough to sort of feel like it doesn't really matter, that it's a struggle for both men and women to be engaged in global health? It's be interested to see if any of you feel you want to speak up on that front. Yeah, let's go to there. Go to the mic over there.
Hi everyone, I'm Rupa from a founder of Women in Global Health, the movement that's really working on bringing gender equality to global health leadership. So this is not my personal belief, but a comment that I've heard in the global health policy-making space, that if you see a room full of women, that's not where decisions are getting made. That's all I'll say.
All right.
That's where all the work is getting made.
Again, not my opinion.
All right. Well, if there are anyone else care to share an opinion on that front. All right. Yeah.
I also want to point out that the trouble, this effect in global health is not different just because it's global health. I think that many of the problems that we're going to bring up in this panel are global to women in general in terms of leadership. I think that sometimes global health and the travel and trying to learn to work across an international community can sometimes magnify some of those issues, so they may feel more acute. But I would like to stress that though we're having a panel today on global health, I do think that in general you could draw parallels with women in leadership in general in medicine.
Well, actually, that brings us to an interesting segue. So we, and actually, yes, please, go ahead, please. Wonderful.
Sorry, I have a question. My name is Angela Wakwe Esamwa. With Global Public Health Linkages, a nonprofit that's trying to foster collaboration between North and South academics. My question is that, have you noticed any trends with respect to those who are in public health or global public health, that they're not necessarily women, and we've faced this before where it's the white male dominance in the world, but have you noticed that it's also more white women, versus women from Asia, from South America, from Central America, or from Africa? Because I've noticed it a little bit, like even when I'm in Africa, people who are at USAID, they're like half my age, have less experience than me, but they're running a whole program, but they're white women. And when I'm applying for jobs like that, I don't get the job, but a young white female gets the job. So my question is that, have you noticed that trend, or am I just hallucinating?
that's a great question. So I think it may be a sort of a complicated and complex answer, but I'd be interested to hear from our panelists.
I don't think it's complex. I think you're totally right.
There you go.
I mean, I think one of the issues is that this isn't something that's been quantified. So it might be an impression you're getting, but no one's really keeping track of that. So that's part of the problem, and that's part of what I think all of us can do. The data, some of the data that Amitha presented was data that we'd collected from Cornell or from academic institutions in the U.S. in terms of how many undergrads are interested, how many of our residents go abroad, et cetera. But there's not like a national survey out there that tells us this, and I think it is interesting to look at some of these other international NGOs. I mean, amongst the World Health Organization, we know that there are very few women, and because they come from the countries that they're from, there's probably more, kind of falsely more diversity there because of the way the WHO works. But yeah, I think part of the problem is quantifying that, and it would be nice to have that information available.
So if it makes you feel any better or worse, we have quantified it in medical schools, and we do lack diversity, people of color, not only in leadership positions, but even in the pipeline. So it's not only in your part of the world. But we're working on it.
Yeah, and we're going to talk about maybe some of the ways that we need to think about how to make that change. So I think that's a great question that we're going to address in just a little bit about sort of solutions. We don't want to just talk about the realities and the facts. We want to also think about how we might move to the next level. So the next arena that we wanted to sort of bring up as a topic is that as part of a couple of Women in Global Health symposia, there's definitely some distinct differences of barriers to sort of being engaged in global health that were raised by those who are sort of U.S.-based global health researchers compared to those who are our colleagues in international settings. And so, for example, in the survey that was done, some of the barriers mentioned for the global health researchers included about a third said mentorship, finding appropriate mentors that they felt that they could really ally themselves with, who are doing global health in a way that they felt spoke to them. A quarter felt balancing life and career was part of the issue. Balancing both the clinical responsibilities as well as the research responsibilities, particularly for those who are medically trained or nursing trained or have sort of a pharmacy trained where they may be going back and forth, they still have responsibilities and how to balance that. And research training, and the sort of least important, although very important, though not explicitly said, was health and safety. So it sort of had, that was the picture that U.S. Global Health survey respondents responded. When we asked those who are in resource-limited, coming from resource-limited settings, the difference proportions were quite striking. So over half, 55% of them actually felt that there were challenges based on their personal and familial life that made being sort of actively participating in global health a challenge. And training opportunities, having sufficient training opportunities, 15% of them felt that there were challenges to finding appropriate training opportunities that had enough funding for them to be able to go and seek training. And then mentorship was much less of an issue, and then health and safety, about 10% of them felt that that was an issue. So I'm interested to hear from each of you regarding those barriers that were identified, whether you agree, and two, do you have any specific examples of those types of barriers? So we'll start with you, Ingrid.
I mean, I think that's so spot on, and I think that in terms of what I've personally experienced, and certainly my colleagues, I would say that the list that you put out there for women who are doing this work in this country certainly rings very true. I think mentorship is at the top of many of our lists. At Harvard, I happen to be in a group where it's predominantly women who are working in this arena, and we've all benefited greatly and feel that mentorship has really been critical for us. I also have outstanding colleagues whom I work with in South Africa who are South African, and I would say that the barriers you list there are very true to their lives, and Not something that we discuss as often in terms of our personal work exchange, but I think that's a very, very true statement from what I've seen there.
Yeah, I mean, I agree with the data as well. With the research training specifically, I can speak a little bit on both sides of it, because when I was finishing up my infectious disease fellowship, I wanted to do research in India, and as many of you who do work in other countries know, you want to spend a lot of time in that country so you can get buy-in from the country, you can get the trust of the team, you can really build good relationships with the team. And it was challenging because I also wanted to have research training, so I also wanted to learn how to use Stata and how to do a survey and how to do all those programs. And our CTSC offers a master's program, but you have to be there every day and take courses like a regular student. And if I wanted to spend time in the field, that wasn't really a model that was going to work for me. But there's a master's program through our clinical epidemiology department that was actually very well suited for us, and I thought this was kind of an interesting way to set it up. It was, what we did is we would have intensive time, like 6 weeks over the summer, where you'd have class from, all day basically, but for 6 intensive weeks. And then you had 2 months where you had no classes at all. So then you could go to your site and you could spend your time there. Then you come back for a month and take another course, and then you could go back for 3 months. And so it really allowed me to have that time to spend in the field and do all the things I just said, but I also got to learn how to do a survey, and I was making my surveys at the same time, so it really worked well with that model. And we've actually used that same master's program for a lot of our colleagues that work in Tanzania or Haiti to get training and research skills. They'll come and do the same thing, because it's very challenging for a lot of these women and men, but for them to leave their kids and their jobs and their elderly parents that they're taking care of to come to the U.S. to do a master's program for 3 years. I mean, that's just not really feasible. The 6 weeks is also sometimes challenging, don't get me wrong, but it makes it a little bit more easy. And one of the things we've actually tried to work on is trying to take the research training to those countries. So in Tanzania, for example, one of our colleagues at Weill Cornell, Jen Downs, has been working in Tanzania for a long time, and she did a whole leadership seminar in Tanzania, and so it was all women from Tanzania, and it was right at the site, and so none of them had to leave their families behind or leave any of their personal responsibilities. They got the training that they needed, and it was all right there, so we brought it to them, which I thought was such a great example, and it was really well received, and the women were really excited about it. So those are some examples of challenges, but also potential solutions in terms of models that could be implemented elsewhere.
Before I say anything, does anyone from the audience want to chime in at any moment? You should just come up to the microphone and we'd be happy to hear from you. Maybe on a lighter note, for those of you that are still pretty young or have small kids, I would say having a good spouse is good. It is one way to address many of the issues that we've been discussing. I went to the Ruth Bader Ginsburg model of home cooking, which was that I demoted myself to B chef and I promoted my husband to A chef. It's been really good for everybody in the family. We have never eaten better. So, just to say. But I did want to say that I think the problems for people in the global north, as we say sometimes at this meeting, and the global south might be different. So at least for people at Johns Hopkins, sometimes when people can't see what you're doing all the time, leadership can't appreciate what you're actually doing. Sometimes I think what you do could be undervalued, and I think some of the travel issues of going back and forth can lead to challenges in work-life balance that I think sometimes are difficult, which even a good spouse isn't always going to solve for you. I think for people in the global south, having lived in Uganda for 5 years, I would say that I was always amazed by particularly my women colleagues having a lot of competing priorities. Their family, their extended family, often as a physician being expected to take care of everybody who was in the family, and the nurturing aspect of being a woman in medicine who's also trying to pursue research meant that they were always juggling more than I felt like I ever had on my plate. I also think that sometimes there was more overt gender discrimination that I was used to in my own university, and it was very interesting to see the gamut of how people dealt with that and to have role models that can help you figure out how to deal with that effectively and diplomatically. So this brings us to the issue, I think, of mentorship and sponsorship. Often it's brought up, perhaps it's even a hackneyed term, but what I like about, I think mentorship can actually solve some of these problems. Many of my mentors were men who really gave me the space and the sponsorship to succeed. I think they can add efficiency, proficiency, help you with many of the diplomatic problems that you have. But I think the problem is that there's not enough women at the top that you can often look to for issues that you might think are specifically related to women. So some things, some potential solutions are senior women trying to mentor a bunch of junior women in group format rather than one-on-one, so that you can try to give some, I'm not going to say words of wisdom, but at least some empathy in the right direction. I also think that my mentor in college was one that did this for me. She was a wonderful Greek woman. I asked her what I could do for her in return for all that she had done for me, and she said, do it for someone else. So the pay it forward aspect, looking down the ladder and trying to pull somebody up. And I think for those of you that are more junior, polite persistence goes a long way. I can't tell you the number of people I've hired or taken on my team because they just wouldn't go away. But I think excellence also helps. So to be excellent and to be politely persistent and keep knocking on the door, I think people want to help. So I think that I think from both ends, those might be some words. And sponsorship, for those of you that are in the audience who have an opportunity to help others, I think that if you can put people forward for opportunities, most rise to the occasion, and if they came to mind, I think you should put their name forward, and sometimes do it in a more deliberative way than maybe has happened in the past.
Great. We have
Since
an
we're going to
audience
be
question. So,
non-traditional.
yeah.
Johanna, go.
Hi, I'm one of the residents at Stanford working with Dr. Berry. Thank you so much for being here. So something you said spoke to me in terms of discrimination that you saw overseas, maybe more so than you saw at your own institution. So what I was wondering for those of us who are rather young and hoping to be leaders in global health, how do you deal with that if you, as a woman, are going overseas and, let's say, trying to run a program or trying to get buy-in from the Ministry of Health or other organizations that perhaps are headed by men and traditionally led by men in a lot of the developing world? How do you sort of negotiate that and remain respectful yet demand the respect that you think you deserve as a leader?
So the first answer is going to be a bit of a joke, but I was going to say, go with the title. It's very helpful. But if short of having a title, I would say that, first of all, I always use the term cultural competence. I think Michelle introduced me to the concept of cultural humility. But whatever it is, I think you should understand the culture in which you're working, or try your best to. And if you don't, seek advice before you judge, because I think that it could be that your colleagues around you will have some insight into what's going on. I think sometimes you can't understand the full spectrum of what's going on, and that if you ask the people that you work with. So make friends, make good friends, and I think really invest time in those types of on-the-ground partnerships, collaborations, and twinning. People that you want to go out and have a drink with can often be very helpful to try to navigate some of those situations. I'm not sure that you can demand equity. Demanding equity doesn't truly work very well, but I think you can be politely persuasive in other ways. That's been my way to deal with it. I'm sure there are others.
Yes, so Michelle would like to comment on this.
So, I completely agree with Yuka that the sexual harassment in the U.S. is a little bit more covert. It's very overt in the developing countries that I've worked in, and also gender bias. In fact, we have a MEPI in Zimbabwe for the last 5 years, and there was not a single woman surgeon that had been trained. So the way we kind of dealt with it, we got the women students. They actually put together a club. I have a dream club. And my global surgeon, Sherry Wren at Stanford, has been mentoring them and actually bringing them over to Stanford. And we have one graduating this year who's going to become a surgeon. So I think we can also work and help lift that bar.
That's great. And I will just point out, just to give I completely agree with the title, and my mentor, Bob Bollinger, who's sitting there in the back of the room, I remember on my first trip to India, he came with me. he basically gave me the title, an important title, and whenever there was a conversation, he said, well, Dr. Gupta would like, is the one in charge of this program now. And so without, he really facilitated that right early on. And it's amazing because I work at a place where there's definitely a lot of gender discrimination in a very sort of hierarchical place. And even though there are a lot of female physicians, there's a huge hierarchical power structure. And so having that right off the bat really facilitated my career in a big way, where I was taken seriously, even though I was sort of junior in my approach. But having my mentor sponsor me, place a title, give me that power was really huge. So I just want to thank you and also give that to a shout out to a wonderful sponsor. So it looks like we have a line of questions. I'd like to hear from our audience.
I just have a comment. I'm Deepa Angar. I'm from Texas, so the big Lone Star State. I'd like to say I started off my residency as an intern, and I was pregnant, so that's where gender bias started. I was very, very nervous when I went for my interview. And my the interviewer was the program director, and he said, so I said, I have a question as I was leaving. I said, I just have to say this, I'm pregnant. And so he said, big deal, it's not a disease. And that's when he taught me a couple of things. He said, this is when you become a leader. Train whoever that is to become, cut gender bias and racial bias. So as a lead, I think that was a comment that stayed with me as a female. We're leaders at home. We are the ones who train the younger generation to grow up. And so that's one of the things I teach my medical students when I see them fresh on the first day. I tell them one sentence. I said, don't see me as a female, don't see me as Asian Indian, but see me as a person. And that's what I want you to learn. That was the first thing. And the second thing that was important, that we have a dean who's the first female. I mean, for us in Texas, it's hard to have women as a dean. So it's Dean Stoll. And interesting, she gave us a statement in her, and she moved from Emory, and her family's still there. And I think for us as women, to see somebody do something like that, to leave family behind and come up and take a position, and she said that she did it a lot for her family to prove a point that leadership doesn't come easy. Sometimes we need to make sacrifices. And in the meanwhile, we have a very prominent, I think she's been there a year, so we have a women faculty forum and stuff. So I think it makes a difference when we reach that, because we set ground for others to go. So
great. Thank you for that comment. Yes, Michelle, would you like to say? Yeah.
I think that's a great comment, but it's a pitiful amount of women that are deans of medical schools. It's less than 16%, because I looked up the numbers for this session. And I just want to tell you that the dean that you mentioned has a trailing spouse, Roger Glass, so she gets global health. She should, or her trailing spouse should. But I think that's a great comment. And then let's take questions rather than do health and safety. I'll get back.
Yeah. Well, we can speak more to that. So just in case you don't know who Roger Glass is, he's the head of the Fogarty program. So I think just for contextual reference, please announce yourself and yeah.
Yes, Johanna, Nodem Internal Medicine and Pediatrics, Wayne State University, and starting a global health pathway for the residents. I just wanted to really make a comment and a brief question, but to really buttress your point to the support system, having a strong support system. There are two reasons I'm here today. One is a husband who is staying home with a 3-year-old and an 11-month-old baby, who I miss very much right now, and who usually is basically on my chest from day zero. I go to conferences, grand rounds, clinic. I do everything with that baby. This is the first time I've been without her. And I'm only able to do that because of my husband, he didn't have a choice. But I left, I left them with him. And granted, he FaceTimes me every 2 minutes, but still, I'm here. But in general, just his support, and he takes care mostly of the home and situation. He's able to do that. The support system is without compare. Also, we're really blessed. My parents live close by. His family too, so that helps. And the second reason is a female mentor who took my rounding schedule. No, first of all, she paid for me to come here, and then she took my rounding schedule. so that, and covering me so I can be here. So the power of women supporting each other for any of us to move forward is without compare. Having a collaborative spirit rather than competitive, and it can be tough, especially in academia, where I don't know if you've heard the saying, but it's academia is so competitive because the stakes are so small. I don't know, but it's one of those things when we are looking out for each other so that all of us move up. It can be challenging, but these are the two key people, and so in my own practice and life, I try to pay it forward, as we say, by encouraging the female learners, my students and medical residents, to have a voice, to trust in their voice, because I've noticed a tendency for females to whisper their answers, to moan or suggest the answer, question the answer. And what is the most common this and this? That, as opposed to that, with confidence. And I keep telling them it's okay to be wrong with confidence. It's okay to be wrong. Don't be afraid. With confidence. That's why you're learning. Then I correct you, and now you know with confidence. And so not to go on and on, but
I was just going to say, that has a name. It's also called the imposter syndrome.
The imposter syndrome, yes.
Right,
that's
people
a very real thing.
that they're usually incredibly well-trained and
Yes.
absolutely prepared for the situation, but pretty sure at the very end that they doubt, and in that doubt, transmit that doubt, and then think they themselves are imposters. So
Right, so every sentence is a question. This is the, this, then, and and it's almost, no, you know this, say it. So what is the best way, so that I can shut up and sit down, what is the best way to come to the table? How in your walk and your experience have you been able to, I guess in a way it is breaking that glass ceiling, but how have you been able to come to that table and made your voice recognized and respected? How have you been able to accomplish that?
So Ingrid, would you like to speak about coming to the table, and how did you make that happen for yourself?
Well, okay, I'm at the table, sure. So a male leader who I know said one time at a talk that men teach each other the rules of the game, and women didn't even know that there was a game. And I thought that was so profound, because so many women I know just put their head down and they work really hard and they're incredibly bright, and they just think they're going to get noticed because they're doing all the work. And I think that unfortunately is not always the case, and I so wish it were. I so wish it were. And sometimes just excellence is recognized even in the quietest voices. But consistently, in my experience and in experience of many other people I know, some of it is really kismet, and putting yourself out there. It's just going for it and knowing that you don't have to be 100% perfect every time you go. And I think that truly has been my lesson. And in medicine, right, it's see one, do one, teach one. I don't necessarily recommend that as a general philosophy, but I do recommend that sometimes we allow ourselves to go out there and maybe fail, but then somebody notices you. I've had a string of events happen in the last couple months where I was out there not even really kind of thinking much about it, but it leads to something else. And people find you that way. So go for it. Put yourself out there. See what happens.
We'll take one more comment if anybody has on the panel, and then we've got a line here, so we've got an engaged audience. So is there go ahead.
Okay, I'm Ann Nelson. I'm an infectious disease pathologist, and I sort of came at this, I think, a little bit different than a lot of people. I was the only girl in a family with 3 brothers, and so I never felt that gender was a disadvantage, because I got out there and did what they did. And when I finished medical school and I was going to start residency, I happened to go to a course on tropical medicine at UCLA that was run by Marietta Vosges, who was a woman who traveled all over and lived everywhere. So the first person I saw as a role model was somebody who never saw a disadvantage in being a woman. And so I went through residency and then went back to get a job at the AFIP, and I wanted to work in Africa. But how do you work in Africa if you've never worked? I mean, the same problem existed over 30 years ago, that if you didn't have experience. So I volunteered and went to work at a mission hospital in northern, what was then Zaire, and while I was there, Tom Quinn said, we need a pathologist at Projet-Sida. So I was in the country, I spoke French, I went down and worked at Projet-Sida, and when we were talking, it dawned on me that I was probably one of the first women supported to do international AIDS work in Africa, because I started there 85, 86. And I did a job, I had a niche job, so I wasn't competing. There was nobody else who wanted to do what I was doing. And I met my husband, got married, had a baby there, and I think I feel the gender discrepancy more now than I did 30 years ago.
That's an interesting perspective. Thank you for sharing that. We have,
Hi, Jeffrey
you
Thiel.
get the title of being our first man at the microphone. Not to draw that in. Please, go ahead.
I come from Ann Arbor, the University of Michigan, engineering. And firstly, I'd just like to say that in my family, I come after two sisters, so I'm used to looking up to women. And I love it, and also just noting, I come from the STEM field, but I mean, I'm going towards global health, but in the STEM field, specifically at the University of Michigan, the BME department, Biomedical Engineering department, has been hiring many women professors, and my experience with that is just phenomenal. And I've learned so much from them, and I can count more than on one hand, probably just two hands, the amount of female mentors that I've had at Michigan. And just to comment, at least at Michigan, they're doing something for women there. And then, secondly, as a young person interested in going into the field of global health, what is my role as a young male? Because I wanted to see more guys here, or not yeah, just.
We see you raise your hand.
Well, just because I would expect that more men should be out here trying to support women in the field. So I'm just wondering, from all of your opinions, what can I do?
So actually, that's a great segue into one of our main sort of questions. So I think you gave an example, and I think one of the things that's happening now is that there is sort of more of an explicit look at what is the gender equity with hiring, with sort of promotion and the like. And so I'd like to hear from our panelists as well as from the audience about sort of pragmatic solutions. Do you think we have to sort of basically make an affirmative action approach or data-driven approach to say, if we have faculty or centers for global health, here's the makeup, here are the number of leaders, let's try to get as many women and sort of try to select more leadership to be female? Or do you think there are other approaches that don't require that kind of explicit benchmarking, so to speak? So I'm interested to hear from panelists as well as from the audience about what kind of ways can we actually think about to promote female global leadership.
So I'm going to make a few comments because I feel pretty strongly about this. I think, first of all, we need to promote excellence. I don't think that it's about promoting women, and I think there are many excellent women out there. But I think one of the things that you can do as a woman that gets into a leadership position is not pull the ladder up behind you, but actually work to get women that are excellent in positions that can make a difference. So I'm a past president of the American Society of Tropical Medicine, and we've worked really hard so that we've now, on all our symposia, you have to have both genders represented, or you cannot have that symposium. You can get a waiver occasionally, but we're working to have gender equity on all the symposia. I have to say I'm embarrassed because it's a society that's 140 years old or older, 1903. We didn't have a keynote speaker that was a woman until 2012. I was the first woman clinician president for 140 years. We had 3 presidents before me. So that is pretty sad leadership, but you can make a difference. So we also, this year, I love this idea, you know how you get medals at these societies? Well, all these dusty old medals for the American Society of Tropical Medicine were male. Walter Reed medal, they're all men medals. So this year, we're going to have a woman. It doesn't have to be for a woman, but it will be named after a woman. And we're kind of like the $20 bill. We're taking nominations now for women that are prominent in tropical diseases. So I think you can when you get, and the other thing is we as women are not good at nominating other women or self-nominating ourselves to leadership positions. And I've been screaming a lot that it's this nominating committee itself, which is all men. You got to put women on the nominating committee also to actually get folks in. So those are some of the.
If I can just quickly add to that, I totally agree with everything Michelle said. And to your point, as a man, what can you kind of do? And I'll just share 2 quick anecdotes about sponsorship. So Amitha talked a little bit about how Bob helped her establish herself at the India site, and I work at that same site, and I had a similar issue where I had a med student who was, or a resident I think, who was sent from Hopkins, who was male, and he was working with me on my project. And then, you know, when we would have meetings with the team about how the project was going, everyone was directing all the questions to him, even though I was the one who had been leading the project for a long time. And so he kind of kept, like, he would answer at first, and then he was like, maybe ask Jyoti, she's kind of been here. And over time, he kept doing that, and he was like, well, as the PI, you know, ask Jyoti, and that continued kind of, I don't want to call it deference, but he kept referring to, you know, kept pointing out, she's the leader, she's the leader, she's the leader, and eventually people started asking me the questions again, even though it was, I mean, sometimes it's just in their subconscious that it's not, they don't realize they're doing, or maybe they did, I don't know, but in any case, he helped kind of redirect them. And then something on a kind of larger scale, you know, we've been talking about the people from the low and middle income countries also. I know Dan Fitzgerald is one of the co-directors of our Center for Global Health at Cornell, not a woman, but he is very passionate about women's issues, and when he goes to, you know, our sites in internet, like Tanzania or whatever, and he's looking for women, or he's looking for students to come to our master's program, he'll say to the deans of those medical schools, I want you to give me 50% men and 50% women. So kind of like what you were saying. Well, great. Excellent mentorship pays forward. So so great mentorship matters. But yeah, so I mean, that kind of thing helps because it, you know, maybe that, because before he'd just been getting men's names because the dean thought, oh, well, it's too complicated for women to come to the U.S. to get training. But when you force them to do it, then all of a sudden, you got women's names. And now we have women that were in the program and that are trained, that are from Tanzania and from Haiti and from these countries where we need leadership also. So just sponsorship, I guess, is the short answer.
So, I mean, I think you've raised there's some real practical pieces that have been raised. One is to actually explicitly, without sort of being offensive about it, but explicitly creating space, medals, you know, requirements in programs, and then actually collecting data to sort of see how well you're doing with that. I mean, and that goes for communities of color. I mean, we do that for admissions, but, you know, there's been so much policy to try to make it a need-blind admissions process, but I think as part of that, then we have much less ability to be explicit about it. And I do think that there are scenarios where you do need to be explicit without sort of making it forced, because you still have to take excellence. The bar cannot be lowered. So it's a challenge, and you need that pool. And I think we have that pool now in global health, and so it's coming up with creative solutions for sponsorship, for identifying solutions that you've mentioned. So Ingrid, you had one, and then we'll take our next question.
I just wanted to add one more thing. If you find yourself in a position of power, whether you're a man or a woman, it's important, again, to get the data, to understand why there aren't women in positions of power. So I have a good friend who is a dean at HBS at Harvard Business School, and she's in charge of new hires. And she was very distressed by the fact that they would extend offers to women. They were really trying to reach out, and women kept turning them down. And this was a puzzling thing. I mean, come on, Harvard Business School, what are you waiting for? Like, go for it, you know? And finally, after all these years, she said, you know what, I need to understand what's going on here, because I've extended these offers to men and they grab it. And these women are like, yeah, I think I'll get back to you. And then they think about it, quote unquote, and then they go away. If you're in a position of power, try to figure out what it is. What is the barrier to that woman accepting that position? And when she dug in a little bit, she just realized as we all know, women are juggling often a spouse or partner who works. There are a lot fewer women whose partners are staying at home. And so they're trying to figure out the logistics of that relationship, childcare, maybe elder care, and potentially all the trickle-down effects, right, in a way that maybe some of the men were not offering. So now she makes these offers and she says, I'm going to make you an offer. I know you're going to say I'm going to think about it, and I'm going to tell you all the reasons why you're still going to say yes, because I have figured out all the problems, how I'm going to solve it. I know where you can get childcare. I've given you my list of all the local childcare. Your husband or your wife or your partner needs a job. I'm hooking them up. She troubleshoots it for them, and it's brilliant. She's gotten all these women to say yes. And so if you're in a position of power, whether you're a woman or man, and you're finding, gosh, I'm just not getting a lot of women to say yes, maybe you want to figure out why and answer it for them.
Great. So we've heard some great sort of solutions. Please come up to the mic and ask your
Hi, I'm
comment or
Amanda
question.
Vogel, National Cancer Institute. So I have two questions. The first is a request. So a few of you have talked about mentorship and sponsorship, and I'm wondering if you could describe a little bit more the difference between those two, and thinking about if you're looking for sponsors or mentors, what are the characteristics you should be looking out for? So that's sort of question one. And then the second is, I feel like there are structures in place for mentoring for early career investigators. So I'm a researcher, non-MD. And I feel like as you reach mid-career, that changes. And there are more informal approaches, different approaches to getting mentoring and sponsorship. So I'm wondering if you have any sort of experience-based recommendations around developing mentoring and sponsoring relationships for people who are mid-career. And finally, I just want to praise you for having this panel. I mean, you're talking about, subconscious bias, people doing things the way that they've always done them, even though there are reflections of subconscious bias, and just having a panel like this is, breaking that mold. So thank you so much.
I think in terms of definition, when people talk about mentorship, I think there are very many different kinds of mentors. I was always taught that maybe you should actually look for patchwork mentoring, that there might be someone who's a scientific mentor for you that might offer you specific advice in the field where you're working, but you may also get mentorship from other people who give you specific suggestions on how to, or maybe a poo-poo platter, a menu of the things that you could try that might work in other areas of your life. A lot of women come to me at Hopkins and ask me for advice. I do first preface it by saying, your spouse is not my spouse, your children are not my children, your extended family is not my extended family. So what has worked for me may not work for you. I will say that putting your children into the clothes they're going to wear the next day saves a lot of time. But, and my children don't know what pajamas are, they never have. But I will say that that's a little bit different from sponsorship. Sponsorship is actually trying to promote another person and offer them up as a person who could lead a plenary or to get an award. And I think it's true that women struggle with self-promotion. I would say that if we had to generalize in general, we're not. So when I wanted to get promoted, and I did get promoted, and my boss said to me, "You need to win some prizes." And I said, "Oh, that's nice, but I don't really know any prizes that I could win." And they said, "You just have to find one and then nominate yourself." And I was like, "But that's not really the way prizes work, right?" And he said, "Yes."
It is for men.
Yeah, so he's like, "If you don't feel comfortable doing that, all you have to do is find the prize, write the letter, give me your CV, and then I'll sign my name to the bottom of it." And I was like, well, that's an interesting approach. So sponsorship can come in very many different flavors. But I would encourage many of you to think about mentorship as sort of a patchwork where I don't think you're going to get everything. It was funny, although Michelle and I were talking about this before the thing, I was looking at Sheryl Sandberg's book, Lean In, where sometimes women don't lean in, and when she was talking about mentorship, she says she doesn't like it when people come to her and say, "Will you be my mentor?" Like, "Will you be my mother?" Or "Are you my mother?" Like that book that we read when we were all small. I'm maybe not so opposed to that. I think that you should ask for help if you think you need help. Maybe the specific question, will you be my mentor, is a little bit off-putting, but you can try different things, like be specific about what it is that you want from that person. And if I, for example, if you came to me, if I can help you, I'll help you. But if I can't help you, I will quickly connect you with someone who can help you. And that takes 2 minutes of my day, and it's really not that big of a deal. So an honest request, asked humbly, is often given. So.
Just to add to that, so like Yuko was saying, you can have excellent mentors that are men. I think almost everyone up here has excellent mentors that are men. But some of the things are gender specific. So, again, deferring to my mentor on the stage. But, when I was starting my work in India, leading a team in a country where, gender parity isn't exactly equal, Amitha was really helpful in helping me understand how to, the persistence of leading a team and just keep showing up and take some of the kind of uncomfortable silences or people not making eye contact with you, but just keep doing it, and eventually they'll see you as a leader. And I was very fortunate to have Amitha as my mentor. One of the things we've done, acknowledging that there aren't Amithas and Michelles and Yukas and Ingrids everywhere.
You just gotta stop.
Well, no, is to so we have a mentorship network that's questions that you can email anonymously, or you can, I think we have a Facebook page now, but you could send these questions. I mean, some of my questions, honestly, I think the first time I went to India, I emailed Amitha and I was like, I hate to sound like a girl, but what do I wear? Because, when you're a man, if you wear what this man is wearing here, that is universal. Everybody likes that. But when you're a woman, it's not the same. Like, I couldn't wear this dress in India. That's not what people wear there. And so even like minor things like that, but it's really helpful to have someone like my male mentors probably wouldn't have been able to tell me what was the appropriate clothing for a woman to wear at a hospital in a city in India. So if you have questions like those, maybe Bob would, but if you have questions like those, you can email us or you can whatever, join the Facebook page, but questions that range from something simple like what to wear, or if you're breastfeeding and you want to know which pump is the best to use when you're traveling, to how do you lead a team in a country where people don't see you as a leader just because of your gender. So just to offer that out for people in the audience who are looking for that.
Well, thanks for those kind words. Let's hear from, you've been patiently waiting. So
no problem. My name's Erica Lieberman. First of all, I wanted to thank everybody for this important discussion, and particularly this sort of presenting the multidimensional and human and feminine face of women's leadership, all these factors about balancing and breastfeeding and whatever, balancing the needs. So I think it's a really different discussion than we would have had 10, 20, 30 years ago, and I think that's really important as we think about what is women's role and women's leadership in global health. So I'm a women's health nurse practitioner for many years of practice in the US, and in the last 6 years also in a global realm in terms of cervical cancer prevention. Now also a PhD student at NYU. And one of the things I think we can't ignore as we're thinking about leadership in global health and emerging leaders in academia and in practice in global health is the sort of parallel hierarchies and gender discrimination and hierarchies in health in terms of the invisibility of nursing in global health leadership. And so I think I came a few minutes late, so I apologize. I don't believe on the panel there are any nurses. Most commonly there aren't. And yes, I did. Yes, absolutely. And I think that we're coming a long way. But I think as we think about, and particularly sort of removing the silos, so that we get to a point where I'm not the one always talking about nursing, but that we can think more broadly about sort of across disciplines. How do we promote nursing leadership? And because it is a lot of part of that's women's leadership, right? And Sheila Davis from Partners in Health, I heard her speak recently about, she's been trying to promote this idea of nurses as system leaders. And I think it's a very interesting aspect as we think about global health and what nurses bring to the table, that we often think about the sort of more direct relationship with patients and the community, depending on the setting and the role, but also as sort of system thinkers and system leaders. And so I think certainly within the discipline of nursing, we can promote that, and that's something we need to do. But sort of across the broader community of global health leaders, I just think we can't ignore that piece when we think about women's leadership in global health. So I appreciate any comments or suggestions.
thank you for that excellent comment. Michelle, would you like to?
I do want to make one comment. I don't want to, I hope this won't offend you, but there's some wonderful men that are nurses. David Valov is a great global leader in nursing. So I just wanted to...
Right, so let me say that I think it's true, as in medicine or any field, increasing diversity along gender lines, along racial lines, all of that is very important. And I think there's an element of supporting women that we have to think about some of that, what nurses have brought, what women nurses have brought. Oh, absolutely. Absolutely.
Yeah, I was just going to say, also, you may want to go to a session, the Afia Bora program that is run by Carrie Farquhar and Johanna Mashallah. I think it is important to come up with ways to break down silos and to help people that are in different areas speak to each other. So 50% of the people that are accepted to that African leadership program are nurses and 50% are doctors. And very many, at the midterm meeting, one of the things we hear the most often, this is now the 5th year of that program, is that it's been really nice to hear a different perspective, to hear it consistently in an atmosphere, in a context where everybody's opinion is equal. And it's no longer hierarchical, and I think it's been really helpful. Recently, we also had a similar situation where we were doing a capacity strengthening workshop for a USAID program called SOAR in South Africa, and there we had 50% people who were in government and 50% of people who were not in government. So maybe this is straying away from the gender theme here, but I think it's important to come up with ways to break down silos so that people can learn to hear each other's points of view. So I think it's a point well taken, but you should think about that. I think, I'm not exactly sure when the session is, but you should think about going to that one.
Yeah, so that gets at the point of interprofessional education, and I think there's been more of that that's trying to be established. We, in fact, there are medical school, public health school, and nursing school actually does an elective where they bring together, and now they think they've tried to add engineers to go into sort of healthcare settings and to be given a project and work collectively on a solution. And so your point about one, obviously just even looking at, we obviously don't have the full range of diversity, and we certainly don't have all the professional diversity, but I think those are important points to be aware of, and so thank you for bringing up that. Let's entertain the next question, and then I'm going to change the
quickly,
discussion.
as you're walking away, can I ask you a quick question? Oh, sorry. Can I just ask you a quick question? In the world of global health nursing leadership, does it tend to be more women? Because it is a female-predominant area, so they're always, okay, so it's not like the few men that are nurses out there tend to go to the leadership positions. You have more.
It is true
female
in
leaders
the U.S. Often that men in nursing tend to assume positions of leadership. It's not that necessarily they dominate, but that
tends to.
It isn't necessarily true that men in nursing has advanced leadership for the field in general. But
right.
So any diversity, I think, helps. But
yeah, I just think that's an interesting.
Right.
Right. Thank you.
Please go ahead.
Thank you very much. My name is Zach Porterfield. I'm a research fellow at Yale and a senior lecturer at University of KwaZulu-Natal. I really appreciate the opportunity and the tremendous role models and sort of examples you guys are able to set. One of the things that we're doing is we're building a partnership, and I'm speaking really on behalf of a partnership between Yale and University of KwaZulu-Natal, which remarkably is top to bottom very heavy with women. Like, I mean, the experts and the truly phenomenal people that we're working with who are really forging this are largely women, which I think is tremendous. I had the opportunity to write with some of my collaborators a grant to an organization that supports women surgeons. I mean, their modus operandi is to support women surgeons. And I made the argument that we have some incredibly talented women, and we were looking to establish a specific program to support the training of female surgeons in South Africa and establish them as leaders in global health through a symposium that we were hoping to set up. And the response I got back was that it wasn't enough bang for the buck, which I felt really shocking. And I thought this was a perfect example to take people who were already leaders and already demonstrating and formalizing that in the sense of, we should create medals, we should create roles, we should create those sort of things. I thought this was low-hanging fruit and a way to have a tremendous impact. And I was hoping to get some perspectives. Some of this is promoting the importance of global health in general, and not necessarily a thing that's male and female, but specifically speaking to the role of supporting women in global health, is there a way to encapsulate that idea concisely so that we can really reach these granting organizations and drive this forward?
Anybody want to take a response to that?
I'm not sure I have an answer for you, but I think we should go back to the sense of diversity. I think brings greater understanding, and I think potentially a deeper understanding of the problems and the scope of the problems. And then if you don't bring more stakeholders to the table, both from an ethnic, gender, many different perspectives, I think you potentially are only going to affect a small, non-generalizable audience. So I might go with diversity, which potentially means gender diversity, but could also mean other types.
I was just going to comment on the surgical profession is very male-dominated, but there's a very active global surgical group within CUGH, and ironically, it's very women-centric. I see one of them hanging back there, so I'll end my statement because I'm sure there'll be more that you'll hear.
Okay. So, go ahead. Would you like to?
I just wanted to make a couple comments. My name is Nadia Samagudu. I'm PhD at the University of Maryland, Baltimore, but I spend 90 plus of my time in Nigeria. I just wanted to say a couple of things that I usually tell my staff that I work with. That, you know, especially as a woman, part of being noticed and being picked up for different things is to speak up. I'm usually telling my staff, I can't hear you. You are making your report, or I cannot hear you. I tell my own daughter when she's talking, you know, I interrupt her a lot of times when she starts and she's half whispering, I can't hear you. You need to say it again. You need to state it properly. So I tell people when we go to meetings, especially in public health and global health, there are a lot of meetings, not meetings as in conferences, but meetings in terms of policy making and whatnot. And if you leave that room or the group leave that room and you never said anything or nobody remembers you, or at least your name, there's really no point in being there. Because typically we come in, we sit in the back, we don't make any comments, we don't ask any questions. So speaking up is important. The second thing is showing up. If we are going to ask to be included and to have more representation for women, you have to make it count. So what I tell my own staff is, you should show up as much as the guys do. I don't want to hear multiple excuses of, I had a headache and I had a pimple on my forehead, or this and that. Because women tend to do that a lot. And I have men telling me that usually when I'm assigned to work with a woman on call or on the roster, I know I have half a staff member, because there's going to be something that she's going to come with, some excuse as to why she can't be at work for this or that. Now, I'm not talking about pregnancy or other things, but I'm talking about general work attendance, because I think amongst women it's lower. If you have a spouse or if you have children, let your spouse, male or female, take care of the children when the children are sick too. We tend to be the ones to immediately take off when the children are sick. So what happens, your spouse will have a very good attendance at work, but you won't. And you don't get promoted because of that. So if you're going to ask for promotions, we're going to ask for equal pay, you need to try and show up as much as the men do, you know, with the exception of some of these conditions like pregnancy. You know. So I just wanted to make that point. You need to show up, and you need to make it count when you do show up.
So thanks. About showing up, I wanted to hear, Ingrid, at Harvard there's a program where they provide conference support about showing up. So could you speak to like this interesting program? I thought it was very enlightening how there was sort of support for showing up.
Yeah,
Tell
absolutely.
us about that.
I mean, I think this is, again, sometimes there are structural barriers, right, in terms of getting women to the table, right? So I think forward-thinking places are already anticipating that. And at all the Harvard affiliates, they have this, it's called a Family Care Travel Award. And it's a constant open deadline, so you don't feel like, oh my gosh, I have to apply in September for a conference I'm going to in March, you know, because usually these things are figured out last minute. And essentially, you can get up to, I think, either between $500 and $1,000 to bring either your babysitter if you want to bring your child, or to pay for care at home, extra care that you need to bring in for your spouse and your child, or anything additional that you're anticipating, costs related to family care, or if you have a care, you're caring for an elder, and you need to get in extra care when you're away. And I think that's just a really small thing. It's really, like, talk about low-hanging fruit, really cheap, but a real recognition of a barrier, so that people who are here perhaps today who, you know, maybe left their baby at home but might have brought a babysitter but didn't want to pay an extra $1,000 for a plane fare and an extra room could easily do that if that's what they want to do.
Great. So I'm going to change the subject just a little bit because in the interest of time, we have a couple of other things I wanted to make sure we covered. And part of it is, and I'm going to, you can certainly come and ask your question in just a moment. So a few years ago, we had a group of US-based anthropologists. They launched a program called SAFE. They did a survey of academic field experiences, and they were actually featured on NPR. And it was a very interesting survey. And basically, they made a shocking finding that was that 71% of female researchers, the majority of those who were trainees, actually experienced some kind of sexual harassment. And I think we had earlier a question about that. And that's often something that sort of at least perceived or thought about is a concern, and this group sort of put some data to that. And that specifically, the alarming number of 26% actually reported a sexual assault. So with that, that's often sort of this hidden or not so hidden topic, particularly when as mentors or as mentees going out into fields where you've never traveled to a new place before, you may be sort of understanding the cultural milieu. What should we be doing about that, and what are programs to address that alarming statistic that you're aware of in the field? Does anyone want to comment on that?
So I can comment.
And then I'll have Michelle.
Yeah, sure. Oh, okay. Just a little bit from what at Wild Cornell, we saw that report as well, and it was PhD students, and the truth is we don't know in terms of medical trainees and medical researchers that go out there what the difference is in terms of prevalence. Although a lot of it is field work, and so I don't know why it would be very different. But that's data that we need, kind of similar to the very first woman who asked her question. We just don't have quantified data about it in medical trainees. But we took it seriously. What we do at Cornell before our students or trainees go abroad is we revised our whole health and safety protocol. We include self-defense training as part of that. So before they go abroad, they get a self-defense class. And then we also make them fill out, a form in terms of kind of emergency contact stuff, but they have an in-country person that's their go-to person, as well as a US-based person that's their go-to person. So depending on what the issue is, what can be done. I think the challenge often with these types of issues is, again, like you pointed out, Amitha, it's the cultural differences. And not that sexual assault is accepted anywhere, but there are differences in terms of, especially if you're a foreigner in another country, that you stand out. And a lot of it is just changing the way that people in at least your research site think and act and behave. And that's a little bit more challenging because we have our own standards that we do in the US, and it's very hard to come to another country and say, well, you have to do what we do because we're the US. That's never goes over well. So I'm not entirely sure what the answer is to that, but it would be nice to have some of the institutions have buy-in, and some of the ones that we've talked to that are our partner institutions, when we bring up this issue, because our international colleagues will tell us, as Michelle pointed out, a lot of these women who live in the LMIC countries experience it at a much higher rate than we do. The deans have been very interested in doing something about it, and they're like, help us. We don't have sexual harassment policies that are part of our institution or even our national rules. Like, guide us in how we can do this. So I think part of it is just starting the conversation and bringing awareness to the issue. And we were surprised, not surprised, but we were happy to know that a lot of the institutions that are male deans were very much interested in implementing new policies to help protect both trainees from our site that come to them, but also their own trainees.
Okay. Please come to the mic.
Hi. I'm Jennifer Kreshak. I'm an orthopedic surgeon. All of my training was done in the United States, and I've been working on the field abroad for almost 4 years. And this isn't really a question as much as a couple of comments. So I find perspective to be very important in relating to some of the comments and questions, which have been incredible, by the way. So when I first walked in the room, my first thought was, what a fantastic turnout. And my second thought was completely different from this young man's, which was, there are a lot of guys here. and I think that's reflective of my own experience and your own experience, right? Similarly, my experience working abroad in a low-income country in a very male-dominated field, all of my local colleagues are male. And we just accepted our first woman into our new orthopedic surgery residency program this year. So I have actually felt less overt discrimination and sexism from them than I have in the United States, which surprised me as well. So I think that the majority of the comments that have been made do apply to the majority of people, but you never know what type of a situation you're going to be in. And in speaking about mentorship and sponsorship, we all would love great mentors and great sponsors. How to find them is very challenging. But along the same lines, if you never really know what kind of a perspective you're going to bring to the table, you never know where you're going to find a great mentor or a great sponsor. And so I think it's important to keep our eyes and ears open because they show up in very unlikely spaces. They show up in chance encounters, which I think one of you said, Dr. Katz, I think that you had spoken to that briefly. So they might be male, they might be female, they might be in your field, they might not be in your field, and again, it might be a patchwork type of mentorship or sponsorship. And so to the younger people in the crowd, the students and the young residents, if you haven't found that person, don't be disheartened. That person will materialize at some point, probably when you least expect it. But be heartened, they're out there. And in the meantime, it's hard, I think it's really hard for women in particular to have faith in yourself moving forward. But you have to kind of try to trust in yourself, even when you're in a tough environment. Also, a separate point, if you're in an unfriendly environment and you're able to get out of it, go to a more friendly environment. Because you don't get points for trying to suffer through a difficult environment. Those environments eventually change, but if you have access to a more supportive, nurturing environment, go for it. And the final thing that I'd like to say is to the point about unconscious bias that one of the other questioners asked. We have probably all experienced some unconscious bias at some point, but a lot of the men that really truly are supportive of women, and I find this especially in older generations, sometimes say something that's a little bit off or do something that's a little bit off, and they're truly well-intentioned. And I think this speaks to socialization more than anything. They truly are trying to help, and they don't realize where they might have misstepped. You know, in my training, I saw this where there were good male attendings that I had, and I found that if I was struggling in a case, they would reach in and take over the case where they might let a male resident struggle a little bit longer. And to learn, we have to struggle. We have to be given that space to go along and try to figure it out for ourselves before they take over. And I don't think that for some of them it was just misogynistic and sexist, and that's that. But for some of them, I think that they truly didn't realize that they were stepping in earlier, or truly didn't realize that they were treating me differently. So I think we have to help people to help us, too.
Thank you for that perspective, and thank you for being the surgeon, the only one right now, and one more added to the club. Okay, great. Come on to the mic.
Hi, my name is Kende, so I'm from the University of Richmond. So first off, thank you to all the women who have spoken today. It's kind of nice just to come in and not be the only one. I've been in so many positions I've walked in, I've been the only one who looks like myself, so it's always nice to come in and not have to worry about that. But I'm still on the undergrad level, but studying global health, I do see a lot of women as my peers, but at the same time, a lot of us come from very affluent backgrounds as well. So how do you guys kind of combat feeling that kind of safer complex when you go abroad and you're working in these environments where if you come from somewhere that's wealthier, if you come from a more privileged or like the global north, and not feeling as you're swooping in and just being the savior, that's not quite what you want to leave or promote in those areas as well.
Great. So talking about the sort of the tension or the recognition of class differences, or where you're coming from a more affluent environment and you're working in a low-resourced environment, and how do you acknowledge that? How do you deal with that? Is that what your question or comment is? Would you like to speak to that?
Yeah, I think I always tell a lot of the people who've never been abroad, who are going for their first rotation, spend 10 to 15% of your time doing things that you think don't benefit you at all. So something that might be perceived as altruism, I don't think there's any pure altruism in general. Everything that you do for other people, you're probably getting something back yourself. But if you do that, that will come back to you in ways that you can't predict. It's a really interesting thing to do when you go abroad, and I've often told people to try that. I think it's a nice way to try to seek to understand, and I think that has held very many of my trainees in good stead.
If you want, there is a series of vignettes that Jeremy Sugarman and myself, we put together on challenges of going overseas. And they're actual vignettes which you can live through. They're actual cases that bring you through things like being a burden on the host, cultural humility, respect, truth-telling. So it's a
GlobalHealthEthics.com.
Yes, it is. GlobalHealthEthics.com. Thank you.
I would just add one more thing. I think one of those tensions is when we go in, I'll just speak for myself. I had this idea of, oh gosh, I know that this is going to be such a helpful strategy for this community. And that is totally shot down immediately. And I would say, especially the first few times you go somewhere, just plan on listening and just being. You know, I'm not an anthropologist at all, but I've worked with many fabulous anthropologists who have told me to sit and be quiet, which is hard for me because you can tell I can chat quite a bit, but it's just the best and most humbling thing. And then I would say double down on a community where you think you could really make a difference and give back. Get them over to the States if that's what they want to do, or sponsor them to, you know, present an abstract at some conference where you think you could help build their career. I mean, I think there's just lots of little micro ways that, yeah, we do. You have to acknowledge we come in a position of power. There is no doubt about it, from multiple avenues. So maybe just try to capitalize on that and try to, you know, give back where you can.
Well, we have only a few more minutes left, so I want to give a chance for our people who've been standing in line to pose their comment or question.
This is a comment. You know, I've noticed that the conversation has spanned from sort of individual actions that people can take, like identifying mentors and sponsors, to policy actions, like a dean identifying, you know, the job for the spouse or the daycare. And, you know, I wanted to make an explicit connection around the policy and the individual. You know, I think that for example, maternity leave policies, you know, there's the national perspective, but there's also the institutional perspective. And having policies in place where only the female gets maternity leave, you know, just then starts off a cascade of events, you know, that speak to some of these earlier comments around showing up, you know, equity issues in relationships, patterns of who works and who doesn't around, you know, and who takes care of the children. And I wanted to encourage people who are here to think about what they can do around influencing policy at their institutions and trying to get at some of these structural factors too, alongside, you know, doing the good work, that's scientific excellence. Because both are influences.
You must be reading my moderator's guide, because that was one of the things we wanted to end on, but we'll have a chance to speak to that. Nancy, would you like to come up to the mic?
Thank you. This has been very helpful. So I wanted to follow up on the, oh, I'm sorry. She's my mentor. Actually, I have no idea who she is. Thanks, Yuka. I'm Nancy Glass from Johns Hopkins, and I wanted to follow up on a conversation we were having just briefly about safety and violence against women, because that's kind of what I do. I think it's really important for us to remember that 1 in 3 women in the United States are going to be abused in their lifetime by a partner or a non-partner. So many of us here, or from around the world, and we're going into countries that 1 in 3. And so one of the things we don't do as women is to acknowledge that and hold our institutions accountable, but also work with our global colleagues on addressing sexual assault and harassment in their country. So I think one of the best things we can do to help our students and the next generation is help them engage in this global issue to address violence against women. So thanks.
So Nancy, just to follow up on that point, do you have some specific programmatic sort of solutions. I mean, we talked about having sort of policies both where there may be, check-in lists or sort of defense training, but could you speak to that a little bit more? I mean, I think you're
I
absolutely
think
right.
it's very key. I think that, there's some really good work that's been done at the institutional levels, which are policy Title IX, the Clery Act that requires prevention and training on campuses. I think making sure that our students have that information, also making sure before we send them anywhere that they have an understanding of the context that they're working in. Not that it's, that they're, most countries women aren't experiencing violence any more than they are here, but an understanding if they're going to a conflict-affected country. Most of it is what they're going to hear women tell them, which are very traumatic situations, and also having a way of responding to women and girls and men who have been assaulted. So I think it's also being able to, as providers, respond appropriately, but there are good policies that have been developed and can be shared, but also understanding the context of and what they're walking into and being prepared.
Can I say one word? So Nancy, I think that's a really important point you bring up, because I have a very good friend that was raped in Malawi, so it does happen. But it also raises a whole other area that I think we haven't even touched upon, which is mental health when one goes overseas. It gets very lonely, it can be very arduous, and I don't think programs do a very good job at actually preparing kids to go overseas around some of the mental health issues and some of the cultural issues, the mental health coming back into the States, where it can be very hard to acculturate. So for those of you who are running programs, you might think about also raising that issue along with sexual violence.
Great. So our last comment, please come up to the mic.
Hi, I'm Zhenya. I'm a physician and I'm an educator. And I was wondering if any of you have had an experience where you were working, whether it be in the global south or somewhere in the foreign country, and you found yourself to be, really the only woman among your colleagues. And how you felt at that time about, I guess, the appropriateness of promoting yourself as a woman, if that's been obstructed, and what impact that might have on your entire mission there, which is not about you.
Well, I mean, I think so to just put your comment into, I mean, I think there's no one right answer to what you've brought up, in the sense that I think there are a few different approaches that can be taken. One is an element of sort of being communicative, being transparent about how the situation makes you feel. And that's not always easy when you're the new person coming into a new field experience. So I think that having that power, having that self-confidence to speak up, we heard about that from some of our other commentators. So I think that it's contextual, and I wouldn't have a one cookie-cutter answer to this point that you've raised. And I'd be interested to hear from others regarding what you would feel.
I was just going to say that maybe you should back up from how you got to the situation where you felt, where you were the only woman. So I think not back up physically right now, but I was just going to say, maybe you should think back to how you got into the situation where you're the only woman, you're feeling isolated, and that you don't feel empowered at all. Maybe that stakeholder meeting could have been set up differently so that you were not there. So what I might do, and I often tell some of my trainees, if there's something that keeps you up at night, there's this whole field called metacognition, but actually you sit there and you think about why you were uncomfortable, how you got to that place, so that by thinking it through and writing it down, or typing it, or whatever it is that you like to do, you might not get in that situation again. So there might have been something about that was preventable that you could have done differently. Sometimes it's inevitable, but it could be that if you could just, like on Who Wants to Be a Millionaire, you call a friend. You get somebody else in the room who shares your point of view. It's been shown actually in studies of gender bias that if you're one, it's difficult to have a voice, but if you're two, it's better. So for all of the search committees for department chairs now at Hopkins, it's been mandated that there's at least 2 women on every committee, because you don't have a voice alone. So I might suggest you call a friend.
So the lifeline approach is certainly a great solution when available. Michelle?
No, I was going to comment. I was going to.
Oh yes, so in the interest of, and we've had, and I've really appreciated all of the comments we've had to date. So Michelle, you wanted to announce
So
exciting.
if anyone enjoyed this session, I just wanted to let you know that on October 11th and 12th, October 12th, there's a conference summit at Stanford where we're bringing in women leaders in global health. It'll be an entire day with female ministers of health, panels on some of the ways to network, personal visions, stories, life stories, and a complete networking day. And that's October 12th. And the website went up. It's WLGHconference.org. Is that correct, Rachel? And if you're interested, the day, we want to make it not just a conference. It'll be a fabulous conference. We have Christiane Amanpour. It's going to moderate. It's going to be, we have great women coming. But if, more than the conference, the day before, if any of you are sort of emerging leaders, which I think everyone in this room is, there is a workshop that the Stanford Business School is going, an executive business school is going to run on how to act with power, how to negotiate, how do women change the dynamic in organizations. And that will be limited to 60 people. There will be a little essay that you have to write, but that's going to be a fabulous workshop. So if you're interested in either the workshop or the conference, again, the registration is open, and we really hope to see you there. And if you can't make it there, we're going to try to, Rachel, we are live streaming it, right? Yeah, we'll live stream it. Thank you.
Great. So I'd like to just give a chance if there's any of our other panelists would like to announce anything or make some concluding remarks. Jyoti?
Yeah, no, I mean, I just want to thank everyone for coming. I think Michelle helped us get this on the agenda, which is fantastic, and I think it was on point. It seems like this is an issue that's on a lot of people's minds, and so I really appreciate all of your contributions. And also, in addition to Michelle's seminar in October, if you want to just talk with us more, we will be hosting happy hour later. So feel free to join us. We're co-hosting that with Michelle's group from Stanford as well. But feel free to contact us, if you go to our website, you can join our mentorship network. We have a Facebook page as well. It's 6 to 7:30 at Bin 1301 Wine Bar. So join us there tonight. But thank you to the other panelists as well, and thank you to Amita for a great job moderating.
Great. Well, thank you to all of you for coming and being a participating.